Hi, everyone. Good evening. My name is Annie Benzie. I'm the chair of the subcommittee for SSAT of the Complex GI Surgery Fellows. And welcome everyone tonight. Thank you so much for joining us. We definitely have a great topic, a little controversial as we'll get into in a moment, but definitely something that is really important for all of us to know because we probably see these patients every so often. And it is my pleasure to introduce our president-elect of SSAT, Dr. Taylor Real. She's a professor in the Department of Surgery at the University of Arizona Banner. And she is a second-time moderator here. And last time she was excellent, of course. So without further ado, Dr. Real, if you wouldn't mind just introducing us tonight for this topic.
Excellent. As always, I'd love for this webinar to the extent that we can be interactive. It's hard for me to see everybody. So if people have a question and you want to put it in the chat, that might be an easy way for Annie and I to follow everything. I'm just going to start by introducing Dennis Graciansky. He is a fellow at Advent Health in Tampa, and he has two very excellent cases to generate a lot of discussion. So I'm looking forward to hearing your talk.
Thank you, Dr. Rial. Good afternoon. My name is Dennis Graciansky, and I'm a fellow at Advent Health Tampa, HPV4 Advanced GI. And we'll talk, as the name suggested, about main and branch duct IPMN and how to diagnose and manage. And here's the brief outline. We'll have two cases that we will I'll present, two a little bit different cases, and we'll discuss them, and then we'll talk about the IPMN. Let's dive in. So this is the 66-year-old male with intermittent abdominal pain, some flatulence, diarrhea every so often, some weight loss, and remote history of pancreatic cysts, but no prior imaging. And he did have, episode of cholelithiasis and several episodes of pancreatitis. He ended up with cholecystectomy. And his family history is pertinent for pancreatic cancer. However, he is not jaundiced. And here is the imaging. So we'll take a look at the CAT scan and MRI. And these are videos. And I'll scroll a little bit slower through them so you can appreciate the pathology. So this is the coronal, and here is the axial view. And from the name of the topic, you have an idea of what to look for. And here is the MRI. Would you like me to read it for you, or you want someone to read
Why
it?
don't we have someone tell us what they see? It's a little hard when you're scrolling through and you're not driving, but
Dr. Jalil, Dr. Jacobs, Dr. Rua, Dr. Lingmaneni, any of the fellows?
Dr. Lingamaneni is just sitting right next to me, so we can ask Dr. Lingamaneni to chime in.
Perfect.
Yeah, we see like the dilated main pancreatic duct extending almost all the length of the pancreas.
Yep, and here's the similar picture you see on the MRIs.
what do you see in the Okay, and a complex cystic lesion in the head and a dilated main pancreatic duct. What are the measurements of the main pancreatic duct?
So here's the imaging. The main pancreatic duct was up to 18 millimeters, And there's this complex cystic mass in the head of the pancreas at almost 5 centimeters. And the radiologist suggested, rightfully so, that this constellation is more likely the main duct IPMN. So the question is, what would you do next? Now you have this the imaging results. Would you go straight to the operating room? Would you obtain more imaging, more labs? What would you do? So we proceeded with some laboratory studies, and we didn't notice anything significant on basic labs, and no tumor marker was elevated. However, here we are prone to obtaining EUSFNA to better delineate the pathology, and that's what we did. And this is the picture from this
I'm
patient.
curious,
Sure.
I'm curious, like, you know, how many people would have gotten an EUS, how many people would have operated, like what, you know, what information were you hoping to get from it?
Right. So anybody wants to respond to this?
Dr. Jacob, you said you would get an EUS?
Yeah, look at the characteristics of the fluid, its mucin content, CEA.
Perfect. So you can see on the picture, apparently, even per Fukuoka guidelines, this picture is enough to diagnose the main duct IPMN. You can see the thick mucin protruding through the major papilla. And then the picture on the top shows this cystic lesion, but probably one of the biggest values of EUSFNA is making sure there's no vascularized nodule that would raise suspicion for pancreatic cancer, as well as it helps to assess the extent of the disease, of course. However, no specimens were collected for this patient. We felt like overall the diagnosis was established, and the patient is a young and it's a main duct IPMN. Hence, we proceeded to the operating room, and we performed a robotic pancreatinectomy. And pathology.
Can I just stop you for a second and get other people's opinions? So, you know, here you have a patient with a main duct IPMN, you have dilatation through most the pancreas, you know, on the EUS, you don't see any mural nodules or anything. So how do you make a decision to do a Whipple? You know, we think this is a field defect. You don't see like a mural nodule or anything explaining the patient's symptoms. CA19-9 is not elevated. Why a Whipple? Why not a total pancreatectomy? What are other people's thoughts? When would somebody do a total? When would somebody do a Whipple?
Hi, Mike Passray from Valley. Yeah, this was always something we did in training over at Charlotte, North Carolina, about not entirely scientifically based. A lot of it comes down to the patient itself, or not entirely data driven. But we would use the age as a big part of it. If it were a younger patient, we likely wouldn't do a total just because that would commit them to a lifetime of, you know, potentially brittle diabetes. And if it were a much older patient, you know, 80s, 90s, we probably wouldn't because the lifetime risk of developing pancreatic cancer was low. But if you hit that middle age spot, that was our key demographic for total pancreatectomy, at least considering it. So that was just one factor.
Other people's thoughts, when do they offer a total in this setting? How old was this patient again? You told me, but I forgot.
66. 66, very active, fully functional.
I think about it sometimes too, like, you know, you did the EUS, you don't see any mural nodule. You know, so then, you know, basically we're treating this main duct IPMN. So does taking out just the head of the pancreas make sense, right? Maybe because that's where the largest portion of that clustered complex cystic mass is, but you didn't see any mural nodules or different things. I might feel differently if there were clear mural nodules, if their C19-9 was elevated, then I'd say, gosh, their prognosis is probably determined by a cancer that started in the IPMN, and I might just do a Whipple. But I think in this patient, I might consider a total.
Hi.
They're committed to a lifetime of surveillance, right?
Hi, it's P. Muscarella. Can you hear me?
Yeah.
I agree. I mean, if the person had cancer, that's why it's good to do an EUS. Because if you see cancer someplace, you're right, their prognosis is probably based on the cancer and not the IPMN. So you just treat the cancer. That's why a Whipple is reasonable. Total pancreatectomy almost makes more sense if there's no cancer, because at least you're preventing them, whatever they say, 70 to 90% chance of getting cancer. So I agree with you.
Sort of counterintuitive. We do a bigger operation when we don't think there's cancer, and a smaller operation when we do. So I was just curious about the decision for pancreatic.
I have a question. I guess it's Juan Rua. Is it more likely that the cancer will develop in the head of the pancreas and then the body of the pancreas, and that's why a Whipple would still be reasonable?
I think, I think the understanding, or our understanding now, is that when you see this main duct IPMN, it's a field defect. And, they've had patients where they've taken out a cystic mass in the head of their pancreas, and then they've developed a cancer, concurrent cancer in the tail. So we believe it's a field defect. So if you take this out and there's no cancer in it, how do we know that, they're still at risk for developing a cancer in the tail? And so to me, that is sort of the argument. Now, is there a higher risk because there's that complex cyst in the head, but it didn't have any solid components, it didn't have any enhancing components. So to me, I don't know, does taking out half the pancreas change anything? Like, I think when we're in that situation, I either think, well, do we do long-term surveillance or do we take out the whole thing? And yes, I consider age, I consider a number of other factors, but I certainly would have talked to the patient about a total.
I hope so.
All right.
This is Mohammed Kreis from Arizona.
Dr. Kreis.
So my only comment is this patient, if we look at the guidelines, has a PD greater than 1 centimeter. So I think going forward with surgery directly, even without an EUS, is part of the guidelines, because this is a high-risk stigmata. I do understand that the EUS would look for biopsies, but if we look at the guidelines, we are justified to proceed directly with surgery. And regarding the surgery, I would favor a total panc in this patient, because if I understood correctly, the whole PD was dilated at 18 millimeters. I would consider a Whipple if the dilatation ended, somewhere at the neck of the pancreas, and we could evaluate the margins of the resection. It would be something that I would talk to the patient about, and that would be my rationale. Thank you.
Yeah, I think that was sort of getting at my initial question, like, do we do an EUS? What does it add? But I do think if there was a clear cancer in the head and we biopsy something, then I think I would probably just do a Whipple, because again, their prognosis is limited by that, and then they don't have the brittle diabetes. But go ahead. I'll stop interrupting you.
So, yeah, most of this complex cystic lesion was in the head, and the dilation was the widest in the head, and the pathology returned as high-grade dysplasia with a negative margin. We always send the frozen anyways, but
so if the frozen came back as high-grade dysplasia, what would you have done?
Yeah, so this is the different. We will discuss it later as well, but you don't want high-grade dysplasia at the margin. It's high risk for occurrence, and for these cases, the Whipple is suggested. So because it's easier to obtain more margin moving from right to left than from left to right.
It was
But
low-grade
yeah,
dysplasia.
so high-grade dysplasia, you don't want to leave high-grade dysplasia
was low grade.
in the margin. Low-grade dysplasia is acceptable to leave. Again, because it's a field defect, so at some point you then just commit to a total pancreatectomy.
Mhm.
All right. So what if the patient had a prohibitive risk for a major procedure? Would you stop surveillance? Would you do anything differently? Would you still watch them, and what would you do? And also, what if the lesion was 9 millimeters, sub-centimeter main duct IPMN?
I guess my algorithm is, if I have somebody who is no way going to tolerate a pancreatectomy, then how does surveillance help me, right? Because if they're not going to tolerate it now, are they going to tolerate it when they have a cancer? So I guess my first question is, would I ever do a pancreatectomy, in this patient? If the answer is no, then I don't know, what surveillance does. So when you say prohibitive risk, that's kind of my thought process. So I will continue to do surveillance in patients who are going to be surgical candidates for branch duct IPMNs or whatever. But if they're never a surgical candidate, then I don't know why we do it, but there are some people who are marginal, right? And you're like, well, if this is benign, I definitely don't want to do it. And I would do something different if we waited, but I'd love other people's thoughts, but I always tell people, I don't want to wait till it becomes cancer, because once it becomes cancer, the horse is sort of already out of the barn. I tell them in my ideal world, I would take it out the day before it became cancer. But of course, I don't know when that is. So.
All right.
And the lesion was 9 millimeters. You're talking about the complex cyst in the head, or are you talking about the main duct?
Yeah, if it's a main duct, but it's a sub-centimeter lesion.
I think to me, then that would depend on the size of the duct itself, not the lesion, so as Dr. Kreese pointed out, a high-risk stigmata is a duct greater than a centimeter, so it would depend a little bit on the size of that duct, whether that was a high-risk stigmata or a worrisome feature.
All right, very good. Any more discussion for the case one, or we can move to more controversial case?
I guess what's your surveillance plan going forward too for this patient, just to tie up all our loose ends?
Right. So this is a high-grade dysplasia. So it's a high risk for occurrence. So this patient needs a lifetime, and we left the pancreas. So this patient needs the lifetime surveillance with initially, given the high-grade dysplasia, some will argue biannual, but at least annual imaging, as long as the patient remains a surgical candidate.
I don't know the answer to this question, so you can tell me anything you want, but what is the risk of cancer in this patient moving forward?
So it also, we have the most accurate answer we would have if we knew the exact biology of this tumor, but anywhere between 1.5 and 6% per year cumulative risk.
Thanks.
Which is significant. And that's why the 5-year survival is surprisingly low for the patients with IPMN. It's better than for pancreatic cancer, but it's still at around 50 to 70%, depending on the series you're looking at.
Would anybody do surveillance more than annually?
I think like a staged approach is appropriate in these patients too, just like any other form of cancer, right? You start them with shorter frequency intervals, and then, if they don't progress, they don't show any signs, then, I think the longer you can stretch it. The question is, right, when do you stop, right? When are they at prohibitive risk? And I think ethically, that's sometimes the bigger challenge, right? When you're talking with the patient and their family.
I think in someone with a main duct IPMN and the beginning, I agree with the staged kind of approach, you know, and if it stays stable for years, then it certainly, I would spread out that interval, but I would probably do at least 6 months in this patient with a main duct IPMN. And then I know there's some data to suggest that we can stop watching them, but kind of depending on the features like this main duct, I would probably continue surveillance on this patient as long as this patient was a surgical candidate, because I think this particular patient probably has a reasonably high risk of developing something in the remaining pancreas.
Also, this patient has a pancreatic cancer history in his father.
Which is something else that might have pushed me toward a total, by the way.
Right. All right. So this is the second case. Also very, this patient is even healthier, a very fully functional teacher. And she came with a known history of pancreatic cysts, and she was diagnosed 7 years prior to presentation, and she didn't have any symptoms. She had no weight loss, no nausea, vomiting, no pain, no abdominal pain, no vague abdominal pain, no issues. And she only had a surgical history of bowel resection due to a vehicle accident. And she did, however, smoke and drink a while in the past. And her primary care was following this lesion. And you can see the sizes 7 years ago and 5 years ago. And overall, in 7 years, in 5 years, it added 5 millimeters to overall size. So this is the MRI for, this MRI was obtained 2 years prior to presentation. Here. All right, this is the axial, this is coronal. Look at how a right angle of the common bile duct. All right, and at that time it was 3.5 centimeters. And let's see, this is the MRI that was the most recent. And just like the last time, if someone wanted to comment on this.
Dr. Luters, Dr. Rua.
I'll be honest, I'm having a tough time seeing it, but I think I see an enlarged pancreatic duct.
Just stop the image on the lesion, you can on that cross sectional.
Yeah, I have the next slide with the stop image where it's exactly where it's supposed to be, but it has an answer. So let me try to here. This image would be the best.
So incident predominant for this one. Kind of like grapes, literally a cluster of grapes down there waiting for you.
Very good. So what would be your best diagnosis at this stage?
Dr. Jacob, do you want to say your thunder?
All right. So and we were talking about the IPMN, and we've already talked about main duct IPMN. So the options are limited. And you can see in these pictures, if you look at this is this patient, and if you look at the Fukuoka guidelines, the pictures are very similar. Look, you can actually see the small branch duct feeding this collection. It's in the uncinate process, so it's a classic presentation of branch duct IPMN. So what would be the next step? Dr. Rial, we can't hear you.
I'd love somebody from the audience's opinion or to put it in the chat. And I'm happy to share mine, but I don't want to. Someone says EUS again. I think EUS is a reasonable start. You know, there's things about this that reassure me. The patient's asymptomatic. It's been stable or growing. I don't have all the old images, but growing very, very slowly over a pretty long period of time. So what did the EUS show?
So no dilation of the main pancreatic duct. So the per MRI, the largest size was 3.6. EOS suggested 2.5. No solid component. And there are several cysts in the rest of the pancreas, but they're very small, few millimeters. And on FNA, thick viscous fluid was collected. All right, and we did the fluid analysis, which is something that we didn't talk much in previous patient. And here is the result. So what can you conclude from just looking at the fluid analysis?
Some of the information is a little bit discordant, but I'd like people's thoughts.
Dr. Rua, do you want to explain why we can manage this expectantly?
Yeah, I mean, I think just from even it's written there that statistically indolent, so I think it's okay to, this is one of those conversations that although the probability is not zero, the risks of large surgery would be potentially larger than the risks of cancer. So I think you can follow the patient and do serial exams if needed. By exam, I mean like MRI or something of that
How
nature.
frequently would you do exams, and what do you make of the fluid chemistry?
I mean, I think a yearly exam, like yearly MRI would be probably be okay. And
so this is a discussion provoking case. And regarding the fluid analysis, oh, sorry. So the CEA is slightly elevated. It's not quite a cut. The cutoff is 180, but still it's slightly elevated, suggestive of a mucinous component. Amylase elevated, meaning it's communicating with the ductal system. And then more newer, this oncogene point mutations, KRAS suggests that it's a mucinous neoplasm, and the GNAS rules in IPMN, and no amplification of tumor suppressor genes is a good sign. That's
Dr.
why.
Go ahead. I said, Dr. Jekyll said worrisome features. Tell me what you expand on that. Dr. Jekyll, can you hear me? Right. He just mentioned, no, he says, so no, Mike, talked about worrisome features. I guess, the only thing I see is the cyst size, and I see discordant cyst size on there, but I don't see any other worrisome features in this patient's presentation. So what do you make of that, Dr. Grasansky?
All right, so what do we make of this? It's a branch duct IPMN, so the risk is lower. The worrisome feature is the size. However, the EOS kind of disproves it. but overall, we have 3 out of 5 imaging, events that showed it more than 3 centimeters. It is IP and IPMN, and the patient is young and otherwise relatively healthy and a good life expectancy. What I didn't mention, the patient was also very anxious about having this this mass, and we always have a conversation with the patient. So we decided to discuss this in tumor board. Given that it's slowly, very slowly, it's not meeting those 5 millimeters in 2 years criteria quite. And if there's IPMN and the patient is fully active and young, and we expect a good, lifespan ahead. But the fact that she was pushing and pushing to get it out. So we decided to go with it, and we took it to the operating room. Luckily, the case went down. The case was quite uneventful, and here's the pathology. It is indeed an IPMN, negative margins, and it's a low-grade dysplasia. So what would you do? What would you do in this case? The patient is you know that the risk is probably not that high, except for the size, and but the patient is really, she doesn't want to live with this thing inside.
Obviously I'm not dealing with this patient directly, but this is probably somebody I would observe, or I would certainly recommend that upfront. Part of it's how you have the conversation, but there are going to be some people who just don't, who can't live with it being in there. Different things. I don't know if the analysis wasn't diagnostic, if it would have changed my initial inclination to observe this. I guess in a fit patient who has one worrisome feature, who's had a little bit of growth of that, it's certainly a conversation you can have. But I think, people have to be really aware of the risk, because she's healthy now, but we can make her unhealthy, at least for a good period of time. With the operation that we do, obviously that's not our plan, but, I think people really need to understand the risk. Dr. Kreese is asking what was the indication. I think size greater than 3 centimeters growth, and then a patient who is very anxious about leaving this in, but I agree, I would have observed this.
Can I say a couple things?
Sure.
I sometimes you tend to think, well, the patient's young, they're anxious, and they don't want to have surveillance, or they don't want to worry about what's going to happen with it. The bottom line is, even if you operate, they still have to have surveillance for the reason you said about it being a field defect. There's still a risk of getting cancer or a lesion in the remnant pancreas. The other thing is, wow, this is like all the way on the uncinate. I mean, that's not always the easiest operation, although most of these people have a soft texture pancreas with a small duct, which this patient did, and that's high risk for a leak. These are the people who get leaks, is people with IPMNs and soft texture pancreas and things like that. I mean, to me, it would be entirely reasonable to continue to surveil this thing, but the guidelines would probably say like every 3 to 6 months MRI alternating with EUS, which is a lot.
Given the size, she definitely does need surveillance, because she has other cysts. I think I saw that go by somewhere, but either way, she would need surveillance. But I think part's how you tell the story and present it to the patient. But, I think people don't understand the risks until they have complications. So.
Yeah. All right, so let's look into something into some interesting facts about the IPMN and something that might change someone's decision making, maybe. So overall, there are three types: main duct, branch duct, and mixed type. And these are the pictures straight from Fukuoka guidelines. You have to have main duct dilation for it to be called main duct IPMN. And it should be, and the reason for main duct dilation should be the lesion itself and not, a stricture from pancreatitis, which is sometimes difficult to tell in this way. EOS is probably one other reason. So this is something I didn't know until the chief year of residency, that apparently IPMNs can be of different histologic types, and the most common overall and majority of branch duct IPMNs are gastric type, and it's all based on this MUC pattern, whether MUC1 is negative or positive, and the type 2 as well as those 5. And typically it's a slow growth, and if it develops into pancreatic cancer, it has the similar course to a conventional pancreatic cancer. Then the most common from main duct IPMN is intestinal type, and this one you see has MUC2 positivity. And what's important is that this one is more prone to skip implantation and is more prone to potential synchronous and metachronous lesions. Then oncocytic type is rare and sometimes can make up a large nodule, and it has a better prognosis. However, it does tend to recur. And then the most aggressive is pancreatibiliary type. Luckily, it's the least common. Typically involves the main duct in the pancreatic head. It makes less mucin, but it gives birth to a tubular and aggressive type of invasive carcinoma. So what is the relevance of this? You can see here that 5-year survival in patients. First of all, this is a sample of 103 patients with IPMNs with worrisome or high-risk features that were resected in Germany. And you can see that 90% with pancreatibiliary type IPMNs actually had malignancy. And if the rest of the types had, and you can see the survival curve, and the pancreatibiliary type had much worse survival, with the rest being in the 75 to 85% range. The pancreatibiliary type IPMN were only 36% at 5 years. So this is also to put IPMN in perspective. This is a large, interesting study with utilizing Rochester Epidemiology Project. And they looked into 2,100 patients who were older than 50. And this, I'm quoting this just so you can have an idea of what the distribution is, at least in America. And you can see that around 10% of 11% of patients had an IPMN. And the older you get, the more likely you are to have IPMN in patients after older than 90 years old. Up to 26% of patients have an IPMN somewhere in the pancreas. And the majority is branch duct IPMN. And if you look at if you stratify them by Fukuoka guidelines, majority are Fukuoka negative, meaning there are no worrisome or high-risk stigmata. And in this study, all of those were branch cysts. And after a median follow-up of 12 years, you could see that none of the patients who had no no worsened features of high-risk stigmata progressed to cancer without first developing worsened features or high-risk stigmata, usually within 5 years. And also, of the rest of the cohort that didn't have an IPMN, 17 patients still developed pancreatic cancer. So, which begs the question where this all IPMNs harbor cancer, or just will make you prone to cancer, or is it just can cancer develop spontaneously just in the setting of IPMN, in the presence of IPMN? This is a Japanese study, which to simplify the numbers, this is 1,400 patients with branch, and majority of this talk is about the branch duct IPMN because the management of it is a little bit more intricate. But you can see that overall incidence of pancreatic carcinoma, and however, they admit it's a little bit higher than expected, and it's Japan, but at 5 years it's only 3.3%, but 15% at 15 years. So, which kind of makes the surveillance seem important. They also suggest that size of the cyst and the diameter of the duct is associated with increased chance of malignancy. And you can see here, these are the numbers that are quoted in the last revision of the Fukuoka guidelines, which were in 2017. And then the mean frequency of invasive carcinoma or high-grade dysplasia in main duct IPMN was 60%. There's a large range, of course, and you can see the 5-year survival is not that great. It's 31 to 54%. It's better than the pancreatic cancer, but still not high enough. For branch duct IPMN, it's a little bit better. However, if you take a look at this in resected branch duct IPMNs, meaning those were selected with, they likely had some worsened features of high-risk stigmata up to a third harbored malignancy or high-grade dysplasia, and almost 20% had the invasive cancer. And there was a question earlier, what is the rate of progression to high-grade dysplasia or cancer? And it's 1.4 to 6.9. Well, this is, however, the branch duct IPMN.
I was going to say that was asked about the main duct. I think it's higher.
So the main duct, so the main duct is expected to be even higher than this. Fukuoka guidelines, this is something that everyone every so often needs to take a look at if they want to remember. The worsened features are the size and the increased, you can see them on the screen. Important that 5 millimeters growth over 2 years is one of the worsened features as well. And for high-risk stigmata are duct more than 10 millimeters, enhancing nodule. And in Fukuoka, from me reading Fukuoka guidelines, it wasn't clear whether the 5 millimeter cutoff is actually stated in the guidelines. However, the European group suggests that it should be larger than 5 millimeters to be a high risk stigmata. So how do we work up the cysts? If it's less than 5 millimeters, no immediate workup needed. You can proceed with surveillance. And larger than 5 millimeter cysts require better imaging. And if there are worsened features, and these are all Fukuoka guidelines, and worsened features are symptomatic patients. The USFNA recommended. However, we mentioned during discussion of the first case that if you have high-risk stigmata on the MRI, this might, depending on the center and the bylaws, it might obviate further testing prior to resection.
Dennis, at your institution, do you, when you see these cysts, like we do a lot of cyst surveillance, you know, do you get a CA19-9 in every patient, regardless of size?
We tend to do, we probably overdo it, but yes, if it's an IPMN, we would obtain CA19-9.
Yeah, I've had a run of the reason I ask, I've had a run of patients who have very benign appearing like pancreatic cysts, and I send a CA19-9 and then it's elevated. And I don't know what to do with that. And I've had like, I don't know if other people have started to see this, but I'm just wondering if, you know, these are people who have like, you know, 5 millimeter cysts, I'll send a CA19-9, it's elevated, then I don't know what to do with it. And I've seen a run of that lately. So I'm wondering if they're not bigger than a centimeter, if we should even send one. I don't know if other people have thoughts. It's not been written about, but.
So then
I usually won't, I agree with you. I usually don't even check when it's below 5 millimeter, because even if I send for USFNA, they can't even see it sometimes. So what's the point? And meanwhile, the patient is very worried. So I'll just do the surveillance a little bit, you know, smaller intervals. Just make sure.
Yeah, if I see these ones that are 5 millimeters, I mean, I usually won't, you know, I'll get like one interval surveillance at 6 months just to make sure nothing's growing, and then I'll just do a year to 2 years after that. But yeah, I've had a couple lately where these CA19-9s are elevated, and then I'm chasing like chasing a number.
Right. So then USFNA has multiple valuable properties. It helps to establish diagnosis. It tells sometimes on MRI or you can see a nodule, but mucin tends to clump into mucin balls, and EUS with the Doppler can to help you tell whether it's the mucin ball or it actually has vascularity, because vascular nodule is a worrisome feature or high risk amount depending on the size, and also the nodule will not move with ultrasound, while the mucinous ball might actually roll. You might be able to squeeze it right and left. And then again, KRAS supports mucinous nature. GNAS supports IPMN diagnosis. I was surprised to see that amylase is not uniformly elevated in IPMN. And you can see that the US can tell you whether there's a mural nodule with, because the presence of it is it increases your risk, elevates your risk by 4 to 6 times. However, up to 10% of branch duct IPMNs with high-grade dysplasia or harboring cancer don't have mural nodules. So it's not, you know, not something written in stone. Indication for a section of main duct IPMN. This is, again, Fukuoka guidelines. Main pancreatic duct more than 10 millimeters, jaundice or mural nodules. However, that's quoted there. However, the majority would remove main duct IPMNs surgically if the patient is fit. Branch duct IPMN is different, however. There are absolute indications, which are cytology positive for high-grade dysplasia and the presence of a large mural nodule. We know that cyst size is associated with risk of increasing risk of high-grade dysplasia or pancreatic cancer, but we don't have a good number. So we have we accepted the worrisome features larger than 3 centimeters, but it appears to be more or less an arbitrary number. And cyst size alone does not warrant a resection. However, the same the same part of the guidelines suggests that in a younger patient with a sizable cyst, due to cumulative risk of invasive carcinoma or high-grade dysplasia, it's probably reasonable to consider surgery. So here's the surveillance for the branch duct IPMN, and for this. So if you've noticed that regardless of the size, it's always a short period of surveillance in the beginning. This is to establish stability. And then if if it remains less than 1 centimeter, then every 2 years is probably the most reasonable time frame. And if it's larger, then you do it again. You get the first repeat image in 6 months to establish stability, and then annually for 2 years. And then if it's still stable, then you can increase the interval gradually. So we also mentioned in the discussion that if it's a larger, and these are again Fukuoka guidelines, latest revision, and we've noticed that we've discussed this that patients with a larger cyst, the surveillance is quite intense and might be expensive in terms of the resources and time spent. This why I wanted to bring up this graph, and it's a little bit busy, but what it suggests is that if it's a large cyst, and it doesn't have it, even if it doesn't have any other worrisome features, still consider surgery if the patient is young and fit. What are the principles of surgery? Uh, uh, the first one is complete removal, but the problem with the complete removal of what the lesion we know and see, because again, it's a field defect. So the only fully complete removal is probably the total pancreatectomy. However, the margin should be negative or low grade. So if the main duct IPMN located at the neck, a right-sided pancreatectomy is preferred. The idea behind it is that it's easier to obtain a margin moving from right to left.
I guess I'm still not sure I agree with that. I mean, I think if they truly have a main duct IPMN, I think, they can have skip lesions. That whole duct is at risk. So I'm just not sure that makes oncologic sense.
Well, that's why I highlighted this thing, so nobody misses this on the screen, to ignite the discussion possibly. And then high-grade dysplasia or pancreatic cancer in the margin, of course, warrants additional resection. If low-grade dysplasia, it doesn't seem to be necessary to resect more. And limited resections and enucleation and similar approaches are not recommended. One of the reasons, several reasons, you can spill the mucus, and apparently some of the cells might implant in the peritoneum, and the patient might develop the pseudomyxoma type picture. But also, if final pathology comes back as pancreatic cancer somewhere in the specimen, you had performed a non-oncologic procedure, so you have to go back and re-resect it, and that's why a formal resection is preferred. And post-operative recurrence, and this is again the Japanese have probably they looked into this the most, and post-operative recurrence is real. And also, what do you do? Do you observe if it recurs, do you observe it, or do you resect? And apparently, these are two cohorts, and the patients who had repeat pancreatectomy had better overall survival. And again, on this accord is that there's a field defect, so we of course expect a recurrence. And you can see that new IPMN progression formation is after 10 years might be in more than half the patients, and in many it will be an invasive IPMN. We cannot avoid discussing this American Gastroenterology guidelines on So this is rather specific cohort. It's asymptomatic patients with branch duct IPMNs. Well, what it suggests that if the lesion is stable, we can stop surveillance after 5 years. And it is also a little bit more restrictive in terms of who gets EUS FNA. So if the pancreatic cyst is less than 3 centimeters without solid component or pancreatic duct dilation, the patient gets MRI after 1 year, and then every 2 years for 5 years. And if there's no change, then you don't need to do anything else. And if EUSFNA is performed only for if there are 2 worsened features present. So this is a little bit too so the criticism is that if you follow the American Gastroenterology guidelines, you're risking missing cancer or high-grade lesions with high-grade dysplasia.
Especially in light of the Japanese data, you show that like the 15-year, incidence is pretty high. I'm curious, people can just put it in the chat, but like, who do people here on this call stop surveillance at 5 years? I'm just curious. That's what I said, Peter. I'm like, no, because I've had ones at 7 years, at 10 years, they change, so.
I think my rule is that they still want to show up to the office and they can get surveillance, right? Because it's so hard to say no.
Oh, but I've seen them. I mean, I've seen them at 7 and 8 years start to change, and the Japanese data suggests that the 15-year, 5 years incidence isn't that high, but 15 years is higher.
Of course, right? It's like appendicitis, right? Not management appendicitis too. It's obviously in the population incidence, right? Is different.
No, I mean, it obviously depends on the features of the cyst too, right? I mean, if it's some small 5 millimeter thing that's not changed in 5 years, then probably I wouldn't follow that, but it's not what we're talking about.
And Dennis, you want to just wrap it up? Yeah, we've got about a minute to go.
Yeah, and we're almost done. So you can see that these are European guidelines, and they suggest only patients who do not require surveillance is those who are not fit for surgery. And then
or have a total pancreatectomy.
Well, apparently it can recur even outside the pancreas. And also the large rectangle in the bottom suggests that the nodule should be more than 5 millimeters, and also the CA99 above 37 is concerning and should sway you towards dissection. Lifelong follow-up in patients who underwent partial pancreatectomy, and patients without significant comorbidities and one or more relative indication for surgery should be considered. So here's the summary. For workup, classify first, make sure you know what you're dealing with. Is it IPMN, or is it a serous or mucinous cystic neoplasm, or is it a pseudocyst? And then establish stability and go from there. If it's a main duct IPMN, you will likely resect it if surgically fit. The question is, what kind of procedure would you perform? And branch duct IPMN, if it has high risk stigmata, and if the patient is surgically fit, resect it. If it has worrisome features, you have options. You can monitor closely, or resect this for if surgically fit in. Surveillance should probably be lifelong, as long as the patient is surgically fit. Thank you.
Thank you, Dennis. I appreciate it. And thanks everybody for coming and participating.
Thank you so much, Dr. Yal, for being our moderator extraordinaire. If everyone wouldn't mind for a moment just putting your cameras on so I can take our formerly known as Twitter picture for this meeting. And you're all welcome back next month. March 25th is our next talk. It is on the use of indocyanine green and near infrared immunofluorescence in surgery. Okay, so everyone smile real quick. Good. Excellent. Thank you. Have a great night and a great rest of your week.